pay back money, which is usually 800, 1200, depending on the insurance, the contract plan, is not much to justify a trip to the operating room and for the surgeon's time and effort to be managing the patient. So any patient who goes through their insurance with absolute certainty will not be getting the right surgery, because the insurances do not pay anything for anything these days, for any of the especially these cosmetic procedures. Another question I get asked is, I was talking to a friend of mine who's a plastic surgeon in the Pacific Coast area, and he was asking me about, he follows me on the social media posts and the Facebook posts and the YouTube. Was asking me, why, I'm removing the implants. And as you will see, I asked him, if a patient comes to you with ruptured implants, what would you offer that patient? And he said, well, you have to remove it. And that is very true. You have to have that appropriate monitoring as recommended by the manufacturers themselves. If you listen to, let's say, Mentor, as you have heard me say, those patients who have had silicone implants, they need to get an MRI at year 3, and then every 2 years they're onward looking for a silent rupture. Another important point to make here, and this is all from the manufacturer, this is not my opinion. The FDA, if you look at their official recommendation, it is to get an ultrasound at year 5, which is more practical, realistic, that patients are going to do it. But if you ask me, the ultrasound is, quote, just sound waves and not the test of choice. The test of choice is an MRI without contrast to look for a intracapsular or extracapsular rupture or a break in that implant. Now, please remember, yes, the newer generation of implants are the gummy bears that we know of, but the implants certainly do disintegrate, as you will see if you look at my Facebook Lives and the YouTube Lives. You will clearly see that the implants certainly disintegrate, they melt, if you will, and they weep out this silicone slime, if you will, that only will ultimately hurt the body. It will travel into the periphery, and it will ultimately, as you will see, the many patients will report that they have, in some select cases, MRI or ultrasound proven lymph nodes that are basically full of silica as well. So not all the patients, but some small select group of patients, even with intact sealing implants, intact silicone implants, and certainly a higher chance with ruptured silicone implants that the silicone is going to migrate into the periphery. Now, if there are any questions, please feel free to ask, and I'll be more than happy to answer. Caitlin and Mar, if you have any questions that come up, please feel free to ask me. Now, the other thing I want to mention here is in my practice, as you will see, I am removing the entire implant plus that capsule and inflamed tissue, like I mentioned early, and the capsule, and this is how I do it. I send the capsules off to pathology to make sure there is no BILCL lymphoma, which is very rare, of rare breast cancer, anything abnormal pathology. In the case that I did Tuesday, the lady had on the right side what was fluid. So anytime there's fluid around the implant, it must be sent to cytology to rule out the BILCL. Remember, any fluid around the implant is pathologic and must be sent to the cytologist for evaluation and analysis to rule out the lymphoma. I take cultures for aerobic, anaerobic, and fungal. I return the implants to the patient. No need for the unnecessary drains. No need for majority of the patients with the unnecessary lift. I basically take high definition pictures and videos of the chest showing complete removal of the entire capsule plus implant, all inflamed tissue. I basically do the twilight deep IV sedations where the patient has no recollection of the surgery. There is no general anesthesia where there is a breathing tube and a ventilator essentially breathing for the patient. And last but not least, all the patients, regardless of age, get the same surgery, so they basically get the benefit of the explant in the manner that it needs to be done, so that once the surgery is done, you have the two reassurances that all of that capsular inflamed tissue was removed along with the implant, and number two, that it was tested. So this is, again, very, very important. I want to also discuss with you, if you go to 10 different plastic surgeons, you will see that without a doubt, you're going to have 10 different techniques, 10 different thought processes, and within the practices of these 10 different surgeons, different ways how they manage patients differently. So it is important for the surgeon, number one, to be doing consistently this whole capsule removal, especially when it is on top of the rib underneath the muscle, regardless of the size, regardless of the contracture, and regardless of the surgeries that the patient may have had. So just this week alone, yesterday I did a case where the patient had caps. The first set was above the muscle, the second and third set were below. So I had to remove the implant and the capsule below. That was the first part of the operation, and the second part of the operation was the residual capsule from her 2007 implant. That residual capsule had to be as much removed as the most recent capsule. So that residual capsule above the muscle was removed after the implant capsule below the muscle were removed. So that was certainly added to the case. It is important to go into the case, and the surgeon must 100% be thinking that the implants are ruptured till proven otherwise. There is a patient I talked to from 2015. She had her implants from 2015. I talked to this nice lady from California, and she had her implant from 2015, and she ended up getting an MRI, which shows that the right side is ruptured. And she was asking me yesterday, what should I do? I said, well, if it's ruptured and there's an intra-capsule or within the capsule rupture, you want to be all containing it. So she said, can I, and should I exercise? Should I ride bikes, contact sports? And the answer is no. You do not want to make that intracapsular rupture an extracapsular rupture where now the silicone is going to spill out to the side and cause more hurt. So you want to be restricting and limiting such that the surgeon will now remove the entire implant and that capsule all contained such that none of the silicone spills into the chest. And that is the absolute etiquette of removing the entire implant capsule as one system without any of that silicone spilling into the chest, and that tissue, inflamed tissue around is also removed definitively, completely, and sent to pathology again, leaving behind all good, healthy, viable tissue. Just today, I managed a patient who came to me, my second last patient. Her husband is a radiologist at a major medical center, and she was telling me he sees patients with calcifications of the implant and the capsule around all the time in 60s and 70s. And I say this is wrong because these are hard balls, if you will, hard masses sitting on the chest encasing what sometimes may be a ruptured implant. It is not healthy, not normal to have a ruptured implant in the body. As I mentioned earlier, implants are not lifetime devices. In reality, what this applies to is if a patient is, let's say, if I have 1,000 ladies that get implants at age 20, there will come a time in the next 10-15 years, as recommended by the FDA and the manufacturers, that they get them at least replaced. And this is where you have to continue to monitor them, and you have to continue to make sure that whatever problems you have, you address them. The other thing, the first thing that the FDA mentions, and please do your homework. Don't accept everything that I'm saying, but listen to what the FDA is saying and what the manufacturers are saying. More importantly, what the manufacturers. Number one, they start off in their warning as breast implants are not lifetime devices. The longer one has them, the higher the chances are that complications will occur, some of which will require more surgery. And I close quotes at this. And this is where all 1,000 of these ladies eventually, sooner or later, will run into a capsular contracture, potential infection, rippling, malpositioning, acute and chronic pain. You will have very rare of rare BIALCL, which has been reported 1 out of 500, 1 out of 600. So it's not that common, relatively underreported, but that can occur. You can have patients with problems with rupture that can occur. And remember, these are not lifetime devices, and they need to be monitored and under surveillance. Yes, please.
A patient or a follower on Instagram said, I've been following you for a while now. I've had my implants saline. I've had them since I was 20. I'm now 55. They are hard, and I have some black sticky fluid coming out of my nipples.
So if you have any discharge from the nipples, you have to go to your breast center and you have to have the breast center work that up. It could be, and remember, 1 out of 8 or 9 women are going to get breast cancer. Now, I'm not trying to scare patients, but these are real hard statistics from the American Cancer Society, and this is what we know in the literature and in real life. 1 out of 8 or 9 women will get breast cancer. Now, I'm not saying you do, but you need, if you have any abnormal breast pathology and it's abnormal to have a fluid discharge from the nipple, you need to go to the breast center and you need to get this worked up. At the breast center, you have the medical oncologist, surgical oncologist, plastic surgeon, radiologist. You have the whole team that's right there. And the pathologist is there, and they will be able to analyze the fluid. They might be able to do an ultrasound guided code, maybe a duct analysis, so that we can get to the bottom of it and find out why that is the case, because you have to rule out any abnormal pathology. There's mucinous discharge, there's bloody discharge that may get hemolyzed on the way out, dark brown matter, for example. Sometimes inflammation I've seen in my patients where there was so much inflammation it was coming out through the nipple areola. But that needs to be absolutely worked up at the breast so that you get that clearance. No one should accept. So, and again, no HIPAA violation here. This doctor's wife, she had hard calcifications around her 25-year-old set of saline implants. And no one should have to live with hard masses on their chest where they're not able to function. She had a grade 3 contracture, which means her arm movement, chest movement was restricted because of 2 hard balls, if you will, sitting on the chest, if you will. And you have to get this removed, and this is going to be a recommendation by any plastic surgeon. Again, this goes back to showing that, look at the example that I gave, the 20-year-old that has implants. There will come a time where you will need to get that removed or replaced. I would say removed is the better answer, because you don't want to be dealing with this in 20 years when you are 75. Because I have taken care of many 75, 71, 69-year-old ladies who have these hard balls sitting on the chest. Now, the other thing I want to mention is you have saline implants. Back in the day, silicone was banned, and saline implants is what you could get if you were not part of an experimental study. And this is why I say clearly the saline implants should have been banned as much as the silicone, because of the many problems that the saline implants have. Remember, saline implants cause the same hurt and misery as the many patients who have silicone implants and ruptured silicone implants, and it is not healthy to have implants long term, especially past the 10-15 years.
And then another question was, can someone with saline implants have a rupture without it completely deflating?
So I have seen this happen in a couple of cases where the valve was a faulty valve, and that valve essentially allowed for some fluid to leak out, and it did not leak out completely. And it did not completely drain. Now, this is where I've said this many times. Saline implants are like a water balloon. If they do, quote, leak, they leak completely. Completely means that the silicone shell of that saline implant essentially collapses on itself, just like a water balloon or an IV bag will, if you will. And you would see, and this is how the saline implants present themselves. So there's this 1 or 2 exceptions to the case, but the vast majority, 99.999% of the patients that I've managed and seen and taken care of, they present with a complete collapse of the saline implant. And this is where you will see, if you take a needle and poke a saline implant, you will see in the next couple of days it will completely deflate and the saline will get absorbed by the body. In silicone implants, you could puncture it 10 times, it will still retain its essential shape because the silicone is relatively much more viscous. So this is also very important. If you take a brand new implant right out of the box, years later, you'll see it has that gummy bear cohesive consistency. This was a very nice selling point, a buzzword. It echoes very well. Anyone can relate to the gummy bear, implant. But this is where, as you will see, just go to my YouTube channel, Facebook, or even if you go on Google and type in ruptured silicone implants, you will see they disintegrate in the same manner as those implants in the 80s and 90s that led to the ban in 1992. So hopefully that answers your question.
And then another question is it common for a surgeon to place one set above the muscle and one set below the muscle?
It is abnormal and wrong, and there is absolutely no indication for it. It is, the technique should be the same, because if you're going to place one below the muscle, the other one should be for symmetry reasons. You will see those implants. If you go to 1,000 plastic surgeons and you tell them to put implants, well over 95% of the plastic surgeons will put the implants below the muscle because that's a better technique, better long-term results, less chance for contracture, less chances of problems such as rippling amongst the many others. In the vast majority of the cases, that implant should be below the muscle. Number one, your surgeon should not be doing implants if you ask me, because that's the right answer. Now, you do not want to change positions because you do not want to place one above. And when the implant is placed above, you will see there is no true muscle to be holding it, and the skin is essentially what's holding it. And you will see the skin will only stretch, just like a lady that will give birth to one baby, twins, triplets, the skin stretches, right? So you will see essentially the skin will stretch, and that will be malpositioned over time versus the other one below the muscle, which will be relatively speaking more secure. So it is abnormal, wrong, and not an ideal technique where the surgeon should put him at the same pocket, ideally below. I have seen it happen before where a surgeon, one of the patients that came to me for explant, the surgeon had placed the implant through the belly button and tunneled that saline implant. So one was below and on the left side was above, because they're tunneling and not necessarily seeing where the implant is going. So I've seen that happen before, and you can see the asymmetry that the patients present with.
Another question is it harder to detect a rupture on a saline implant versus a silicone implant?
Saline implant, as I said earlier, it will deflate. You will notice in the next couple of days that this side is much less compared, which is the ruptured side versus the non-ruptured side. So there will be a marked volume difference. Silicone implant, even if you have 1,000 plastic surgeons examine the patient with a ruptured implant, they will not be able to conclude what is a definitive rupture. And majority of the times, this is what literature calls a silent rupture. Silent rupture means that the patient has been examined by the surgeon and the exam is unremarkable, normal. And now when she goes and gets a MRI, it shows a rupture. And so this is what is a silent rupture. This is why the manufacturer, and this is what I mentioned earlier, mentor says get an MRI at year 3, and then every 2 years they're onward looking for a silent rupture. And I've taken care of many patients where the surgeon thinks these are just 9-year-old or 7-year-old set of implants. It cannot be ruptured, and they go in and they find out to their surprise that the implant was ruptured because the patient's exam was unremarkable. The exam means nothing, and ultrasound usually would not mean anything, and neither will a mammogram. The best imaging choice that we have in 2024 is an MRI without contrast, looking for what is a silent rupture. I don't mandate that on all my patients because I assume all implants are ruptured till proven otherwise, especially when I go into the operating room. One day I did 2 cases back to back where the MRI was read on a patient to be normal and it turned out to be a ruptured implant. And the very next case on that Thursday morning, the implant, the MRI said it is a normal implant and it turned out to be ruptured. So the MRI is not a perfect test, but the best test that we have out there. It's without radiation, it's without contrast.
Another question says, it is uncomfortable to lay on my side with saline implants. What is possibly going on?
So what happens is, as you will see, just like with anything, with any saline implant or silicone, the gravitational pull will pull the implants downward and outward. Majority of the times, you will see that the implant literally falls through the muscle, which gets attenuated and atrophied over time. And now the implant's moving downward and outward. You may be developing a capsular contracture. You may have that implant now sitting on the proximity of maybe a nerve. And causing that pain, especially when you're sitting on the side or sleeping on the side. And so that malpositioning is now putting that implant in a place where it's now impinging on a nerve, causing the pain. That is, or unless you have a capsular contracture. Remember, implants are not lifetime devices. The longer you have them, the higher the chance you're going to run into problems, some of which will require more surgery. Quote unquote, this is what exactly is the first warning of the FDA, and you will see that over time the gravitational pull will position it in the proximity of or capsular contracture that will cause the hurt.
Someone said, please speak about your knowledge on silicone in the lymph nodes.
So this is a very good question. If you look at the studies done by Dr. Henry Dykman or Dr. Atul Mehta, pulmonologist out of the Cleveland Clinic, who published silicone emboli from intact saline implants. And I want you to go to my Facebook page or YouTube and type in Dr. Mehta, Mehta. He's the chief pulmonologist at the Heart and Lung Institute at the Cleveland Clinic in Cleveland, Ohio. And he published a very interesting case report where a patient had silicone that was noted within the lung. Now we know any abnormal pathology, inflammation, cancer, whatever it may be, it will drain into the lymph nodes, and the lymph nodes that serve the breast tissue are in the armpit axillary area. And you will see there are a lot of lymph nodes, 15, 20, depending on the patient. And so this is where the debris, the badness, whatnot else gets translated to. Let's say if I get a bad mosquito bite on my big toe, the groin lymph nodes will ultimately light up because that's the defense mechanism. If I have a bad ear infection, the lymph nodes in the neck will light up. So going back to the chest breast area, if you have the silicone that's now within the lymphatics, it will drain, because remember, it is, and I asked Dr. Mehta, and I know the answer, but as you will see, it not only spreads to the lymph nodes, but it travels to the other areas of the body. So if you look at Dr. Henry Dykman and another lady that she had a ruptured implant, and when she passed away, she donated her body to science. And Dr. Dykman did a histological biopsy analysis of the spleen, the liver, the nerves, and he concluded that there was silicon deposits at different varying concentrations in different parts of the body. And this is, again, part of that silicon toxicity that affects the body and the system as a whole. Now, I've been just given the 3-minute warning. We will try to keep this limited so as to not make this lengthy. I will continue to do these TikTok lives, Facebook, YouTube, and Instagram lives so I can answer the questions. Please join the Facebook group page and the YouTube page. You will learn. Remember, you're not making a decision. Right now, the whole purpose is what? For me to give you objective evidence, not my opinion. Anything that I have said today is not my opinion. I'm just highlighting the obvious. So to the many ladies, millions of us who have the implants, not only in the US, but all over the world, who have implants, this should not come as a surprise that they're not lifetime devices, or they are not. Some patients come to me and state that my surgeon said that your implants should be in your body for the rest of your life is incorrect, wrong information. What I'm just like the FDA mentioned, if you have problems, you need to be getting the appropriate surveillance. If you have problems, you need to seek attention. As you will see, there is a defined problem and there is a defined solution. So going back to the lymph node point, we know this because of the imaging, MRI, ultrasound. Sometimes biopsies are done because these lymph nodes can get large, 1 centimeter, 2 centimeters right at the surface, and the histology shows that there is silica within. And what is the source? We know that it is the implant. We know that the many capsules that are removed, you will see within it the foreign body, giant cell reaction, chronic inflammation. Some patients, as you will see, the histology shows within the capsule there is non-polarizable material consistent with silica within the capsule. This is precisely the reason why the capsule must be removed. And I'll end with this. This is where that silicon is leaching out. Dr. Henry Dyckman shows this very well. And from day one, the silicon particles are migrating, breaking off molecular microscopic amounts into the periphery and causing the hurt that we know of, where the body starts reacting to this foreign body. It is not inert like a stainless steel hip implant or a titanium or a pacemaker. The silicon is leaching off and now causing the hurt and the misery that we know hurting from. So it shows up in the lymph nodes and it shows up in the other tissues, not all, but this is precisely why the implant capsule, all that inflamed tissue must be removed so that there is no inflammatory burden left behind. And now the patients are improving on their quality of health. And you will hear the patients directly that they subjectively have sought improvement, especially after when their gummy bear implants were removed, intact saline implants were removed, and certainly their ruptured implants were removed. Having said this, it was a pleasure to be on again. Till we meet next time. Thank you again. This is Dr. Khan, Executive Plastic Surgery.
Can you hold
Yeah,
this?
yeah, yeah.